joining us. I am going to let everyone come in for a few minutes, so we'll start in about 2 minutes. Hi, everyone. If you're just joining us, we're going to start in about 1 minute. All right, we're going to go ahead and get started. Thanks for joining us so early. If you're on the East Coast, a little later. But anyway, I'm Adrienne. I'm the dental applications engineer. I'm a dental technician for 18 years. And I also have Jim Deere here from 3D Systems. He is the North American channel manager for Nextdent. So if you have any further questions after the presentation, feel free to contact us. I'm really looking forward to hearing Dr. Curry and Brian give us their presentation. This is actually just a taste of what's coming. We're going to be hosting a large course from beginning to end to help you get started, answering all of your questions and help you see how to do everything that they're doing. So just a quick intro, Brian is the owner of Synergy. He specializes in full digital workflows for immediate load implant dentistry. He's a recognized specialist at the Coys Center and a founding member at the Coys Study Club in Atlanta. He was previously the Georgia Academy, the president of the Georgia Academy of Cosmetic Dentistry, and he's a key instructor for 360 Imaging, Noritake, Aman Gerbach, and Shofu. And so he'll probably be showcasing a lot of that as well. Dr. Curry is dedicated the last 10 years to implant digital dentistry. He's one of the owners of a 6-office practice in Atlanta, where he performs the majority of the surgery in the group. Dr. Curry is also a part-time instructor in the GPR at the Dental College of Georgia. Dr. Curry and Brian Linke have been working together for years on dozens of full arch and full mouth rehabilitations. And I'm sorry, I am reading this because they have such great credentials that I didn't want to miss all the important stuff. But anyway, again, we're looking forward to seeing what they have to show us today, and I will now give the floor to them. Please go ahead and utilize the question and answer, and I will either ask the questions at the end, or we'll address them later if we run out of time. So with all due further ado, thank you guys.
Thanks, Adrienne, and thanks for the introduction. And we'd like to thank LMT for inviting us to speak today, and 3D Systems as well. So I'll let Dr. Curry kick off.
Yes, absolutely. Thank you guys so much for having us today. We're excited to share our workflow with you guys because as you mentioned in our intro, Brian and I have been working on this for years to try to improve what has been traditionally a kind of a laborious and sluggish process, in our opinion, on how to do full mouth and full arch rehabilitation. So we're trying to share a fully digital all-on-X dentistry approach here, and we really truly try to harness the power of technology in every aspect of what we're doing here, from planning to execution. So we're excited to show you what we've got today.
So we're gonna have kind of a rapid fire run through this because obviously we can't cover everything in detail in the allotted time. So we're going to give you a 30,000 foot view, pretty rapid fire. But as Adrian alluded to, we're going to develop this into a much bigger, more comprehensive module-based application for everybody. So what if you see today looks interesting to you, then it will definitely be available in a deeper dive in the future.
All right, so I'm going to introduce Tanya here. Tanya is our patient of the day. And one of the things that strikes me about Tanya, or struck me right when we met her, is, you know, she's actually about a 31-year-old patient in this photo. And she, in my opinion, does not look it, at which, you know, we've all known that lip support and cheek support and everything is so important for your facial profile and for a youthful look. But, you know, the picture on the left is a 31-year-old that looks like a 51-year-old or older sometimes. And in the right, she is wearing an upper denture. That's how she presented to us. She did not have a lower denture because she threw it away. She hated it so much, it was uncomfortable, wouldn't stay put, so she just threw it away. So when she showed up like this, we did still have to do a tiny bit of classic dentistry, meaning that we still need to follow all of the same principles of a full mouth rehabilitation or a denture case, meaning we go through a detailed facial analysis appointment, whether you have teeth or not. But Brian is present for that appointment. He and I and the patient go through all of kind of their hopes, dreams, and goals, but we also follow all the classic facial analysis steps that you're seeing here listed. And the main thing here is Brian and I have really tried to trim down how many appointments this requires, because, you know, historically, dentures or hybrid dentures are going to be a 5, 6, 7, you know, many appointment process. And we've got it down to about a 4 appointment process for most patients.
Yeah,
typically, sorry, go ahead.
That is huge. And typically on a single arch, we nail it pretty much routinely with 4 total appointments. If it's a dual arch, there may be an additional appointment in there with trians just to verify everything, but we'll show that as we get further in.
So here's just classic dentures where we're getting her video correct. You know, we need to make sure that we actually know what height of occlusion we're doing. And so there you can see an occlusion rim. That's about the only analog dentistry part that we did in the beginning because she didn't have any lower teeth or lower denture. And at the bottom there, you can see some shade tabs that Brian has made for us that we use to get her gingiva and her lip color just right. And obviously a face bow on the left there. Just again, classic dentistry to get the planning correct, but at this point, it allows us to shift into a digital format.
So those shade tabs you see are actual shade tabs that we make. The shade guide itself is from Smile Line, and the composite is the Annex Gum composite, which I feel like is the most aesthetic, natural looking colored tissue type composite. So we use the actual composite, make the tabs and make them available to our clients to take shades because we're going to use that composite on our provisional and on our final. So this keeps everything very, very consistent.
And here you can see that we've converted to digital, and you know, and traditionally, if you're having to do a denture setup and everything, you're going to end up sending back and forth to the lab to get an occlusion rim, get a wax setup, do a dual scan protocol. But for us, once we got that occlusion rim, we're off to the races digitally. And the difference here is instead of waiting for back and forth a week's mailing or 2 weeks or whatever to have a setup, Brian's able to virtually design this very, very quickly. He emails it to me. I can play with it in 3 dimensions on my computer wherever I am. And then I can respond with tweaks. He can make those tweaks instantly or within a few minutes to hours, as opposed to waiting for, you know, another week or so of back and forth with mailing a case with small adjustments and requests. So this process is very fast, which allows us to streamline how quickly we can see the patient, because one of the things I've found is when a patient emotionally and mentally commits to the idea of getting a hybrid denture done, they want it yesterday. And they've been walking around with whatever they've got for their whole life, for decades. And the hurry up and wait process is very frustrating for them. So it's a very big kind of, you know, win for the patient, and enrollment's very high, and people are very, very pleased with how quickly we can make it happen, because if they've been shopping around, a lot of offices can't do it as fast as we can.
And for us as a lab, this is a critical step, being able to design everything digitally. We're essentially setting the case up prosthetically and restored, so it's restoratively driven. it's imperative that we get this to the restorative dentist and the surgeon a lot of times to get eyes on it, give us any feedback, make changes, and confirm that we're all happy with it before we move forward, because everything is reverse engineered inside of these arches. And you'll see that as we go through here. So once we have the prosthetic design and it's approved, we overlay that with the CBCT scan that we receive, and then we virtually place implants according to what we expect or what we know or what we've already discussed a little bit with the oral surgeon. And in this case, Dr. Curry being an oral surgeon and the restorative makes it a little easier. So we know what brand he likes. We've got an idea of the distribution of implants that he prefers. So we'll preemptively drop those in, schedule the join me meeting, get online. And again, we can all be anywhere outside of the office as long as we have access to Wi-Fi and a laptop, or even an iPhone for that matter. We can go through this plan together and tweak the implants restoratively and surgically to set up the most ideal distribution and bone quality and quantity selection for the case.
And this is hugely helpful for me as the restorative dentist and the surgeon, in that I've done these cases with a number of labs in a number of ways over the years, and half the time I'm having to kind of back and forth with paper copies or screenshots with a lab, trying to have them tweak what I want them to do. And as the surgeon, that's very frustrating. I want to plan my own surgical protocols, but in this case, Brian and I are in real time making adjustments where I can say, hey, can you move that implant a millimeter this way or half a millimeter that way? Can you give me a different angle? He can quickly measure, make sure that his restorative space is still what he needs for the materials that we're using for this case. He can quickly adjust what abutment heights and angles and everything. So we can very quickly modify and tweak where we're both assessing from our own perspectives as the surgeon, restorative dentist, or the lab technician, so that we're all happy and we all have a dry run of a surgery that's coming up. So we all have our minds on the same page, and it's really, really helpful for on the actual surgery day. We've had a perfect walkthrough of this, so we're 100% on the same page.
And that's a great point, because we actually do the surgery twice before we actually do the surgery. So we do it virtually, and then we at Synergy do it in the lab, because as you'll see, we print all the analog models and put everything together and stage it, set it up as if we were doing the surgery. And then we do it on day of surgery with Dr. Curry, who actually does the surgery. So one of the things that we choose above and beyond the implants and the abutments at this point is the actual guide. So if you look at the bottom right of the screen, that's an anatomic bone-based guide, and that's our go-to in the maxilla. It's very distinct in the way that it operates and the benefits that it gives us. And we're going to talk about that now, but that happens now. So all the determinants get decided in this meeting, actually. So what we want to do after we have that meeting is get the doctors to sign off, surgeons, restorative, whoever's on the meeting, and then we quickly go to fabrication. So we take the implant design and then we design the guides virtually in our software. We use the 360 DPS software to do that. Then we print the guides and all the guide models, the bone reduced models and the dentate models, in the lab, and we mount and cross mount everything. And we actually have the parts ordered and sent to the lab, and we stage everything, where we actually put analogs, multi-unit abutments, titanium cylinders, everything gets put in the models, again, as if we were going into surgery and doing it on day of. So everything gets timed. If you notice on the bottom left, the guide has some orange dots. Those are timing dots. So everything that we can do in the lab to make efficiency and consistency better on day of surgery, that's our goal. That's what we try to do. We try to make life easier on day of surgery. So we have everything timed out. We have everything down to the tiniest detail planned into the guides. This is a close-up of the anatomic guide. So the difference, and we're going to look at the comparison here in a minute, but the difference is, if you look at the top left, what you're seeing is a very, very small guide that actually rest directly onto the facial plate of the bone after the tissue's been reflected. It gets screwed into place with 3 or 4 screws into bone. So it's extremely rigid. On this particular one, it actually goes into the floor of the nose, and you'll see that a little closer as we go. On the bottom left, you see a cross section looking occlusally at the bone being, after it's been reduced, and you can see the intimate contact fit of the guide to the bone. That all happens on 3D printers. The Nextdent 5100s are our preference. We print everything we do on these printers, and we print a lot of different things just because of the selection of materials that we have. So one of the things we're printing is the provisional. And with that, we're printing a composite arch of teeth as a continuous arch, and we're milling a trilower base. All of our surgical provisionals have a reinforced base, whether it's a milled chrome base or a milled trilower base with a, we call it an aesthetic mask, composite aesthetic mask that is bonded on top of it in the lab. And then we aesthetically finish it out with a pink composite. Our provisionals do not break. That's one thing early on that everybody has problems with just milled PMMA or printed composite standalone. You do have the risk of breakage because it's just not strong enough. And we deal within minimized restorative spaces. So, we're talking about 7-8 millimeters as opposed to 16 or 17 on a lot of the cases that we do. So we have to reinforce them. And by doing that, it allows us to have beauty and strength. So this is a look at the finished arches on the models in the guides, all set up, ready to go for day of surgery. So you'll notice that on the bottom middle picture, we have some cylinders. Those have been shortened, and we do a special treatment on them to make them more retentive, to be smaller in diameter, shorter, so that they're hidden within the structure once we pick it up, and maximize the connection to the restoration.
And this screen right here has just a bag of things that I love that have made my life so much easier, from the fact that we're fixating these with bone screws instead of big pins, which will show you an example of contrasting 2 different cases I've done at the same time to show you what a big difference it is. How anatomically these guides sit against the bone. That is so helpful as a surgeon, in the sense of there's no flexure or cantilevers of unsupported areas, because historically, if you're trying to put a guide over bone, it has to be able to avoid the undercuts, and it just sticks off of the bone, and that it just naturally comes with inaccuracies. The fact that these pin into place, all the prostheses and everything pin in with those metal pins that you can see, those are much more reliable than some of the printed pins and larger pins that we've seen that we've have to deal with, that are pushing against the lip or the cheek, that causes flexure again, and just it's a real bear to get them in and out a bunch of times. These are very easy to take in and out. That foundation guide is rock solid, especially when it's going into the floor of the nose. The actual materials, like Brian was talking about, the strength of these things. I had one patient, dual arch patient, where that's the highest risk that we can have, dual arch immediate load. Once she was in her temporaries for months, when right around the time that she was supposed to come back to see me to finish out, she started having seizures from a new medical issue of hers. And so she was having massive seizures repeatedly, almost every day for months and months, was hospitalized. And so her teeth are slamming together in the worst, most dangerous kind of way. And she was off grid for me for close to 1.5 years. And these arches held up for that. They survived what most teeth, natural teeth, and absolutely acrylic dentures could not. And that was just a lifesaver for us as far as her case going fine. And it turned out beautifully. She's doing well health-wise, but that, the strength of those should not be underappreciated, because it's hugely helpful. And the occlusal views that you'll see at the bottom there, while I'm doing the surgery, this is a prosthetic dream for me, in the sense of when I pin that arch into place and I look down those holes, just like you're seeing here, and we can see the pre-trimmed cylinders that Brian's done for me, where it's just, he's got every single site queued up for me. It's very efficient, very methodical, and it's very, very predictable and consistent, where you're not having to take the denture in and out and pour it out and try it back in. And it's, the tedium that is just the traditional, we avoid that entirely, because this is all done in advance and is just the smoothest process I've ever experienced for this type of surgery.
And that's why we term it differently than traditionally. This is not a conversion. We're not converting anything. We designed it specifically to be a connection. So we call this a synergy surgical connection, because we're, that's all we're doing. We're just connecting it to the implant cylinders. We're not converting anything. So just another look here, the anatomic guide. Again, you can look and see occlusally the bone reduction. You can see the intimacy of the guide to the bone. And you can see how small both upper and lower guide are. They're only on the buccal. They don't go over onto the lingual. So there's less tissue reflection, as opposed to this case that Dr. Curry did with another system that he mentioned earlier that think he wants to give you some details on.
Yeah, this was just a nightmare of a day, where you can see how long these pins are. And this bone-borne guide has to go both buccal and lingual. And so the reflection that you have to do on the lingual is huge and pretty unnecessary. And what we did, or what we've converted to with the synergy approach, you don't have to reflect the lingual at all if you don't want to, until you're actually doing the bone reduction, and you can do the smallest amount possible just to make it safe. But this thing at the bottom, you'll see, I mean, the reflection is way far down, way further than it needs to be. Those pins are huge. And this is a very petite lady. And Tanya, who we're talking about today, she's 4'11", and she is about 88 pounds soaking wet. And so a tiny mouth is a very difficult thing to work in when you have a cumbersome, bulky guide. This patient at the bottom, she's also a small, petite lady. She's not as small as Tanya, but you can see the stretch on her cheeks. In that bottom right picture, the biggest stress of my day was getting those guides in and out each time, because you have to pin and unpin. And those pins were pulling on the commissure of her cheeks so much. I was afraid that she was going to have a laceration there, which, how embarrassing and inappropriate is that? We can't have a wounded cheek or lip just because the guide can't fit. That's a horrible, that's a surgical failure in my opinion. So this guide was an absolute nightmare to deal with. This was the last time I ever did that system. And it was before I met Brian. Once I met Brian, we were like, we can't have any more of that. Let's fix this. And so he's done a wonderful job of coming up with lots of creative solutions for things, making my life better, my surgeries faster and easier and safer and more predictable. So the bottom is a thing of the past, but if you ever have a guide option of this nature at the bottom, know there's a better way, and do not do that.
You want to talk about that?
This has become my favorite way to attach a maxillary guide. Obviously, in this case, Tanya has no maxillary teeth, so we can't do a tooth-borne guide as far as, oftentimes if they have teeth, we can use the teeth to support the guide to figure out where our fixation pins are going or help stabilize it while we get it. This is actually a nasal floor stability. So you can see in the upper left, that's me actually elevating the floor of the nose right there in the piriform aperture. And it's just like a little sinus lift, and you really don't have to lift it up very far, just barely over the edge. But there are these two little latches on the guide that fit in there, and the positive seat that comes with that is rock solid. It is unlike every other guide approach I've ever used, where even with tooth-borne ones, oftentimes when we're taking out these teeth, there's a reason, because they're periodontally involved, or they're decayed or broken down, and teeth move some, or they flex, or whatever it may be. In the months of planning while you're making stuff happen, the teeth are shifting or whatever it may be. This is super repeatable, very predictable, rock solid, and it's just compact and out of the way. As you can see, those screws are flush with the guide. They're not sticking out at all as far as the pins go. So just a better way in general.
And just by comparison, if you look at this guide with the bone reduction and the drill guide in place with the little flat push pins, it's not even pushing on the lip at all compared to that previous picture, the other guide that we showed. So the low profile, very diminutive, profile of the guide is huge on day of surgery. Timing dots, so with the osteotomies and the implants are drilled and the implants are placed, we can line up the timing of the implant with the guide. That allows us to put the cylinders in place, put the provisional, it drops down over the cylinders. We put these crazy great red tubes inside the titanium cylinders, squirt our pickup material, and we use a Kettenbach resin cement, Semcor for that. And these tubes allow, block the access to the titanium cylinder, so the material can't get inside there. Once we light cure it, it sets up, we pull these tubes out, and now we have an extension of the hole, and we have the perfect size access for our multi-unit abutment screw.
And quick comment on the lips. Notice the only reason the lips are being held out of the way are because we're doing a bit of a retraction just for the photo. You can have the entire prosthesis guides, foundation guides, all that in there, and the lips just drape around it, unlike the pins that were about to stretch that lady's lips to the point of laceration. The whole thing can be in it. We've actually had 2 guides in there at the same time without any issue. So different world entirely as far as ease of use.
So in the lab, again, a part of our process, we, again, set everything up, we stage it. So on day of surgery, we know where these cylinders go. We have them in little tubes with abutments, titanium cylinders, red tubes, labeled, ready to go. So it's a rapid fire succession to get parts in place in the right position. And then the red tubes, you know, we know in the lab, the tube goes in here, how it's going to come through the restoration. So it's same exact setup and process and benefit in the mouth on day of surgery. These tubes, I just want to mention these a little bit more. We use these throughout the process. We use these on a daily basis, not just on day of surgery. These are a godsend for us in the lab because we do a lot of different restorations where we have a structure, whether it be Trilor or titanium, and we're putting either a composite structure over it or zirconia crowns over it, and we have to bond everything together. So in order to keep access holes clean and the right size, we found these tubes to be the best thing possible. We've tried everything else, including wooden sticks and different things, rolled up tissue. Nothing works like these tubes. So you can get them from a website, company Flow 3DT. They're, you know, they're affordable. And once you try them, you won't do any of these processes without them. So implants are placed. We pick up the provisional. Dr. Curry sutures things up. This is how this case was sutured with these particular suture caps. In the last, last couple of months, we've been switching over to these suture caps.
Yeah, the last handful of months we've switched to this, which is a design that Brian helped create when I was talking about, you know, various complaints on the ones on the left were the best things that we had at the time. They're kind of mushroom shaped, but they're pretty short. And so depending on the tissue height, sometimes they're great and sometimes they are swallowed by the tissue, or when you take them off, the tissue just collapses down, or they're wide enough where 2 of them are close together and they're kind of banging into each other. Brian solved that with making some flat sides so that we can have 2 next to each other. And these are taller before they blossom out. They hold the tissue out of the way better. They're much easier to suture around. They make it much easier when you take them off to have the prosthesis just drop right into place. And those little flow tubes that he was talking about a minute ago, they also make my placement easier because the actual hole that my driver goes through is almost exactly the size of that hole. There's very little play in there, where traditionally if you got a big denture tooth hole drilled out, you know, there's some play, and so there's any kind of wiggle room just slows you down. So these things just drop right in typically.
Yeah, and if you've ever done one of these cases, you know that there's a lot of processes that are challenging along the way, and if we can make those easier and more consistent, you know, surgeries get completed quicker. This is a big step right here when we take these suture caps off and put the picked up restoration over the abutments. If you look at the lower right picture where the tissue caps have just been taken off, and you can see how the tissue is displaced out. That doesn't always happen. And if you don't have good tissue management when you're suturing, you really have a difficult challenge trying to get the restoration in place, get it seated down over all this swollen, weeping tissue onto these multi-units and get those tiny little screws to engage. So this is a huge advantage in that regard, just to, you know, kind of set the stage for an easy delivery or easier delivery.
So we're getting down to the last couple minutes here, so we'll go really quickly here. But here you can see the surgery day provisionals in place, very predictable, just like our digital version that you had seen a second ago. And it's just such a pleasure to work with this, in the sense of it looks exactly like we planned it just about every single time. I mean, and you just really can't say that about most other guides. It gets you close, but not exactly spot on every time. And this one, we've done lots and lots of these at this point, and they are very repeatable and very predictable.
So we have a unique process that we do. Once we connect the restoration and then I take it back into the lab and finish it out, we capture it virtually with some scan analogs. And this sets us up for our multifunctional appliance, or MFA. This file is iOS scanned, and it's sent back to the lab. So when I get back to the lab, I have 3 months to 4 months while the implants are integrating to make a multifunctional appliance, which essentially is a printed copy of the surgical provisional. And we know that surgical provisional, we know tooth position relative to those freshly placed implants. So we can stage and set things up so that we have arches that are segmented between an implant and an embrasure space with a shell over top of them as a carrier. So on the first restorative appointment, Dr. Curry removes the surgical provisional, he screws in the segmented copy of it. He lutes it together in the mouth, takes a quick impression underneath. He also does an aesthetic, phonetic, and functional and occlusal verification. So we're rolling about 4 or 5 appointments into one appointment with the MFA, which really reduces chair time, obviously. That comes back to the lab with me. We put analogs on it, and we pour it up, and we go back to an analog setup where we have an analog model, and then we can also then scan that back in, and then we can do our print to try-ins. We print with MFH. It's a very aesthetic, strong material. We could print arches quickly and accurately with it on the 5100, and that allows us to deliver, like a week or 2 after the MFA try-in, a printed composite aesthetic evaluation. And we do this on all of our dual arch cases, just because we want to make sure before we commit to going to final that we have all of our bases covered. We've got a check off from restorative dentist and the patient before we commit to the expense and the time and effort to make the final restoration. So this is Tanya at the day of try-in. So we get to make some tweaks. The great thing about the MFA, because it's composite and not PMMA, it is a reductive or additive procedure. So if Dr. Curry says, you know what, I don't like the length of the centrals, I want them to look like this, takes a little flowable, adds it, and says, here's where I'd like you to go with that. Tweak the occlusion, whatever we want to do, that can all be done at this point with composite.
All right, we're going to be cut off here in a minute and a half or so. So just kind of showing the very last little bit here, we can verify everything in the lab that it is truly what we want. And like Brian said, I can do all of those appointments in one fell swoop. That's your verification jig, your final impression, your wax try-in, all of that in one appointment, which is amazing. And we all know time is money and nobody wants to take these things on and off all day. So doing that to have a really efficient flow to end up with this beautiful product at the end is just an absolute godsend.
So Synergy Titanium is our go-to. We do it 95% of the time. It's a milled titanium structure with tooth preps. We do individual high translucent gradient zirconia, almond Gerbach zirconia crowns over it. And then we finish out with the annex gum composite. Very small footprint, easy to clean, very, very aesthetic. It's much more aesthetic than a full arch monolithic or even layered zirconia bridge. It's stronger, it's repairable. Zirconia full arch is not. It's lighter. That doesn't make a difference to me or the patient, but it's become a thing that people talk about. But it's just an all-around win-win-win type scenario for the restoration. So here's the day of delivery, beautiful keratinized tissue that Dr. Curry was able to save and manage around the implants. You can see on the left a X-ray of a reinforced provisional upper and lower, and then you can see our framework at the final on the right. And then we give you the final Tanya.
And you can see that she's looking back to being a young, pretty 30-something as opposed to a prematurely aged 50-something. So this is one of the unique cases where we really got to give somebody their youth back, which usually we're giving back confidence and chewing and comfort. But this is one of those where I felt like we gave somebody back her youth, which is just an incredible thing.
And you know what I noticed, Andrew, when we do these cases and we see these patients, the eyes tell the story every single time. I mean, it's just so telling. It's not just the smile, it radiates through their eyes. It's incredible.
Life changers.
All right, so we are ready for questions.
Hey, so we've got one question that was typed in. It's why do you prefer 360 imaging, so many fully guided solutions available. What sets it apart for you two?
The software is much more comprehensive than any of the other systems that we've worked with. And, you can use free software. Blue Sky Bio, for example, is a great single unit guide software or onesie twosies, but it's just not developed to the point comprehensively to do these type of cases as efficiently as the 360 DPS software.
And then the next question is, why titanium prep superstructure and not PEEK or pectin superstructure? Why choose titanium?
Good question. So because of experience and because of breakage and because of losing money and losing faith and the risk of discomfort and challenges for the patient and the restorative doctor. So if we're going to go through this process and we're going to go to the length that we do to plan everything and orchestrate it and get to this point, why take a shortcut and use a material that is not going to be a long-term bulletproof process and hold up? And for me, my personal opinion, and I've got nothing against those other materials, I think there are applications for them, but I think some materials get overused and overutilized. And I think that, I like to say technology is great, but we have processes and materials, and just because you can do something doesn't necessarily mean you should. So I think we kind of get off track and get carried away. These cases have to be planned, and that we have to know not only restorative space, but distribution of implants and flex forces. And that's why we always default to titanium, because at the end of the day, when these restorations are finished and they go in the mouth, no one can tell what that structure is inside there. You can't see PEEK, you can't see another material, you can't see the titanium. So why not put the best, strongest material in there? And personal opinion, but that's how we base it.
And we've tried all of those materials, and we've had successes and we've had failures, and we've learned from all of them. And the restorative space required for the titanium and zirconia is about as minimal as I've ever seen as well. So it's very strong, even when you have to be in a very thin area. And again, the flexure that we've seen and battled with here and there is just, why take the risk when we have the option that's so predictable, so strong, holds up over time, doesn't fracture, and is repairable to, if you had some kind of crown getting knocked off, say somebody got into a car wreck or something, you can fix it as a single tooth or, like a natural tooth prep, that kind of thing. But the framework itself is just so strong and reliable that it's become our go-to for almost every case at this point.
So I think we have time for one last question. It's from Jack G, and he's asking if you have any experience with Exoplan.
I have some experience with Exoplan, and again, I think all of these plans are good, but for the level of complexity that we're working with on these cases, we've just had the best experience with the 360 DPS, just because, again, it's built for these type of cases, whereas those other plans are gaining and they're getting better and they're moving in that direction. But we found some limitations when we get to this level of complexity and planning. And within the 360 system, we have the availability to do the bone-based anatomic guide, which you can't do that in the other systems. And so that's how we run. We run with a bone-based screwed-in guide, not a cantilevered pinned-in guide. And that's really our deciding factor on the software.
We're getting a lot of just thanks again from 3D Systems and Nextdent, guys, for doing this. A fantastic presentation. We're getting lots of notes in the chat just saying great presentation. And then just a final question, do you teach courses where people can sign up to learn even more about your process?
Great question. Yes, we will be.
And thank you, guys. Yeah, we really appreciate it. This is one of many cases that's very similar to this that we would look forward to showing you guys in our larger, more expansive courses. But yeah, we'll absolutely be doing stuff in the future that you guys can come and do stuff in person with us.
And we will we'll make everybody aware of that. I know that 3D Systems will be making some ongoing availability and some announcements about some webinars and hopefully some future hands-on live surgery courses that we've been talking about doing. So stay tuned.
That was an amazing presentation. Thank you so much. I can't wait to take one of the courses, even though I'm not going to be doing the surgeries. So anyway, that was great. Guys, stay tuned. Again, we're going to do a collaborative effort with these two, and we'll be sending out a lot of different announcements in the near future. Feel free to come to the booth if there's more questions, and Brian and Dr. Curry are also going to keep an eye on those as well. So from Gemini, we'll see you later.
Thanks, guys.
Thanks again, guys.